Hello, I'm Dr. Tom King, and I'm the medical director at Immunovia. Today, I wanted to talk about clinical diagnosis and diagnostic aids for the diagnosis of pancreatic ductal adenocarcinoma. Clinical diagnosis is still an art, even though it's advanced greatly in the last 100 to 150 years. Diagnosis is still something that's accomplished within the mind of the healthcare provider, and they have to reach a diagnosis that is confident enough to make appropriate therapeutic decisions. Clinical imaging and laboratory tests underpin most of the advances in clinical diagnosis in the last 50 years. Another aspect of clinical diagnosis that I think it's important to recognize is that it's almost always a process rather than a single action. It's very unusual for a single presentation or a single test to yield a final definitive diagnosis. Typically, a patient's clinical history and their clinical presentation or complaints will suggest a differential diagnosis to their clinicians. And that differential diagnosis is really a list of all the possible disease processes that could be responsible for those changes. It's very important for the clinician to consider a wide differential diagnosis, because if something is left out, it may be missed during the diagnostic process. This differential diagnosis then serves as a scaffold for additional investigation that will hopefully lead to a final definitive diagnosis. In this way, diagnosis is really an iterative process in most cases. Although a few tests may be done at one time, usually there's a sequential aspect to this. And oftentimes, at least for serious illnesses, as this diagnostic process progresses, it moves from less invasive to more invasive tests, so more patient risk may be associated with it. At the bottom here, we've shown a paradigm for the diagnosis of pancreatic ductal adenocarcinoma. And the upper one is the one I think would be common and is the likely approach. In this case, imaging studies such as an MRI may lead to an endoscopic ultrasound, where an endoscopic probe is placed through the esophagus into the duodenum and then applied directly to the pancreas. If this is further suggestive that pancreatic cancer is present, an actual tissue sampling, in this case a fine needle aspiration, can be performed either percutaneously through the skin or through the wall of the duodenum into the pancreas to detect a lesion. What's really almost never occurs is that a single test, in this case we've shown an MRI, leads to a definitive diagnosis. These tests simply don't have the sensitivity and specificity to alone lead to a specific diagnosis. And it's really the combination of these findings, either in parallel or sequentially, that leads the clinician to reach a specific diagnosis. I wanted to illustrate this with an example case study that could lead to a diagnosis of pancreatic cancer. In this case, an elderly patient comes to their clinician complaining of back pain, and this triggers imaging studies to evaluate whether they may have a disc problem in their vertebra. In this case, the imaging studies identified lesions in the pancreas, and what I've shown here at the top is a diagram of a normal CT scan for your orientation. You can see here the pancreas is this somewhat ill-defined organ that's very deep-seated within the body. The bottom has shown our patient, which has some low-density lesions within the pancreas that are suspicious. They could represent pancreatic cancer or PDAC. They could be a neuroendocrine tumor. They could be a benign tumor or cyst in IPMN or an intraductal papillary mucus neoplasm, or they could represent chronic pancreatitis. Now, depending on the findings within the CT scan and actually the skill of the radiologist in interpreting them, you may be able to rule out some of these possibilities, but it's very unlikely that you will lead to a specific diagnosis. As a matter of fact, one study has shown that the specificity of CT scan for pancreatic cancer was only 43%. So Many times a CT scan will suggest pancreatic cancer when it's not there. It's some other disease process going on. So imaging findings like this are very likely to trigger additional testing, which may escalate from non-invasive testing to more invasive testing to distinguish between these diagnostic possibilities. This type of diagnostic paradigm that I've described is very typical for how different types of laboratory tests and imaging are ordered and utilized. And as I've said, I want to emphasize it's very rare for a single test to provide a definitive diagnosis. The real value of non-invasive testing is to act as diagnostic aids that can really facilitate the diagnostic process to make it temporally and financially efficient, and if appropriate, to avoid invasive tests that will cause real risk to the patient. The goal of identifying diseases earlier when they're more treatable also pushes you towards multi-modality testing, because you're trying to find smaller lesions, and when they are in deep-seated organs, the types of tests that can be performed are less than 100% sensitive and specific. So aggregating together the results of multiple tests can be much more useful in terms of reaching a specific diagnosis early on when the disease is much more treatable. I wanted to also emphasize that there are real limitations to even the most invasive types of tests. In this case, showing a needle biopsy of a pancreatic ductal adenocarcinoma at the bottom, corresponding to the CT lesion you can see there with the hypodensities within the pancreas. Needle biopsies can fail because they may not be appropriately directed into the lesion. In this case, you can see that the pancreas is quite deep-seated. The lesion is not that well defined, and targeting it exactly can be very difficult, whether that targeting is through the skin of the back or is through an endoscopic ultrasound probe. So one can simply have a miss. One can also have confusing results because of concurrent infection. Pancreatic tumors can cause pancreatitis, which is an acute or chronic inflammation of the pancreas by blocking the duct. Sampling of that may lead to a false negative diagnosis. And so for all of these reasons, these more invasive tests may yield a negative result inappropriately. And one study found that cytologic sampling of the pancreas by FNA was only 85% sensitive for diagnosing patients with PDAC. For this reason, having multiple different types of tests that measure different aspects of disease can be very useful in terms of managing the diagnostic process optimally and ultimately managing the patient's care in the most useful way. Also, they can be useful in either accelerating or decelerating the diagnostic process and the move to more invasive tests so that individuals can be diagnosed earlier in their disease process. I hope this has clarified some of the aspects of how different types of testing can act as diagnostic aids in the diagnosis of pancreatic ductal adenocarcinoma. Thank you for your attention.